So with that, I will go ahead and hand this over to Dr. Lauren Lee. She is the senior guidance writer for the VDH Health Information Team. She's been with VDH for about a year. She's been doing just a heck of a lot of writing about COVID, Mpox, and whatever the disease at the moment is. She's also a co-lead for the clinician outreach team, including Sofri and myself, for this VDH Mpox response. She received her education at different places. Williams College, University School of Medicine is where she got her medical doctor degree. In St. Louis, she did her residency at UCLA Medical Center. She got her master's in public health and epidemiology at the University of California in Berkeley. And then she's done a tremendous amount of work in other communicable diseases and epidemiology, a lot of it in California with all different types of things. So she's very well knowledgeable and here to talk to us a little bit about Mpox.
Good morning, everyone. It's my pleasure to be here. This is our very first Mpox training session, and we've been planning this for quite some time. And so I'm really excited to see so many faces, so many people in attendance. And why don't we go ahead and get started? So I'll start with an overview and some background on Mpox, and then we'll move on to talk about the epidemiology of the 2022 Mpox outbreak. I'll discuss ways providers can collaborate with public health, and then I'm going to share a few resources and conclusions. So we'll start with some background on Mpox. It's a rash illness caused by the monkeypox virus, which is an orthopox virus. It belongs to the same group of viruses as smallpox, and it's a zoonotic infection, meaning that it can be spread between animals and humans. Now, before the 2022 Mpox outbreak, Mpox was rare in the United States. Mpox symptoms are similar to smallpox symptoms, but they're milder. And the type of Mpox that's been seen in this outbreak is rarely fatal. More than 99% of people who get this form of the infection are likely to survive. And Mpox is not related to chickenpox, even though they have similar names. I'll go through the background of Mpox pretty quickly. It was first discovered in 1958 in Denmark when there were 2 outbreaks of pox-like disease in monkeys that were being kept for research. The specific animal reservoir is not known, but African rodents and non-human primates might harbor the virus and infect people. The first human Mpox case was recorded in 1970 in the Democratic Republic of Congo during a time of intensified efforts to eliminate smallpox. Monkeypox virus is a DNA virus in the genus orthopox virus. This genus also includes variola virus, which is the virus that causes smallpox, as well as vaccinia virus, the virus used in the smallpox vaccine, and cowpox virus. The virus has 2 distinct clades that were renamed by WHO experts in August 2022 so that the names would be in line with current best naming practices. Clade 1 is the former Central Africa or Congo Basin clade, and this clade causes more severe infection with a case fatality rate as high as 10%. It also spreads more easily, so more person-to-person transmission is seen with clade 1. And clade 1 is classified as a select agent. Clade 2 has been identified in the current outbreak. It's the former West African clade. It's the former West African clade, and historically this clade has caused less severe disease, and it's not classified as a select agent. And clade 2 consists of 2 subclades, 2A and 2B, and 2B is the one that's largely circulating in the current outbreak. So in recent years, the epidemiology of Mpox has been changing. Before the 2022 outbreak, Mpox cases were reported in people in several Central African countries like Democratic Republic of the Congo, Central African Republic, and Republic of Congo due to clade 1 virus, and in Western African countries, including Nigeria and Sierra Leone, due to clade 2 virus. Now, in these older reports, human cases were reported mostly from rural forested areas in Central and Western African countries, or in countries with cases related to travel or migration, or in people who had been exposed to infected mammals. Now, since 2014, the annual number of Mpox cases has been increasing in Africa. And this reemergence of disease might be due to a combination of factors. So things like environmental and ecological changes, animal or human movement, the end of routine smallpox vaccination since its eradication, improvements in disease detection and diagnosis, and genetic changes in the virus. And from 2018 to 2021, human cases were reported from 6 African countries, and DRC and Nigeria reported the most cases of clade 1 and clade 2 virus, respectively. So let's transition and talk about Mpox cases here in the US. Cases in people outside of Africa have been linked to international travel or imported animals, but these reports have not been common. Now, in 2003, there was an outbreak of 47 suspected and confirmed Mpox cases from 6 Midwestern states, and all cases were linked to contact with pet prairie dogs. So the pets were infected after being housed near imported small mammals from Ghana, and this was the first time that human Mpox had been reported outside of Africa. The investigation found no infections were caused exclusively by person-to-person contact, and there were no additional reports of Mpox cases in the US until 2021, when 2 travel-associated cases were reported. Both of those case patients had traveled to Nigeria, and CDC and state health departments investigated those cases and did not find any further Mpox cases in the US at that time. Now we'll move on to discuss the current 2022 Mpox outbreak. So a little bit of background about that outbreak. In early May 2022, UK health officials announced a confirmed Mpox case in a person returning from Nigeria. Additional cases were identified in the UK, and some occurred in people who had not traveled to an endemic area or had a known epidemiologic link to the other cases. The number of cases rapidly increased and expanded to other countries, and it was noted that these cases were occurring primarily among men who have sex with men. The first US case was reported on May 17, 2022, in a Massachusetts resident, and on May 23rd, CDC launched an emergency response that emphasized surveillance, testing, medical countermeasures, and education. Additional cases were reported here in the US, and the first presumptive Virginia case was reported on May 26th, and it was confirmed the following day by CDC. Cases to date have been reported in all 50 states, Washington, D.C., and Puerto Rico, and all cases have been from clade 2, specifically clade 2B. WHO declared the Mpox outbreak was a public health emergency of international concern on July 23rd, and that means that it was an extraordinary event that posed a public health threat to other nations through the spread of the virus, and it required a more coordinated international response. And that WHO declaration ended on May 11th, 2023. Now, the 2022 Mpox outbreak has been unprecedented with its worldwide spread and emergence of cases in countries that have never reported Mpox before. It was the first time that there was sustained person-to-person transmission, primarily spread through sexual contact. And this figure shows the distribution of Mpox cases across the world. The orange dots represent countries that have not historically reported Mpox, and the blue dots represent those countries that have historically reported Mpox. Larger dots, like the one that you see over the US, indicate a greater number of cases reported from that country. As of December 27th, the most recent data that's available, there have been more than 92,000 Mpox cases reported from 116 countries with 171 deaths. And this figure shows the epi curve by month for cases June through November 2023. As of that date, the majority of cases reported in the past 6 months were from the Western Pacific region, represented in this figure in green, followed by the region of Americas in blue and the Southeast Asia region in orange. 96% of the cases with available data are males with a median age of 34 years, and males 18 to 44 years old make up 79% of the reported cases. Sexual encounter was the most commonly reported transmission event, and for cases with information available, 85% identified as men who have sex with men. 52% of Mpox infections were in people with HIV, but these data were not available for the majority of cases. During this outbreak, the U.S. has had the most Mpox cases of any country, with more than 31,000 cases across all 50 states, Washington, D.C., and Puerto Rico, and 56 deaths, with 2 of those deaths reported in Virginia. This map shows U.S. Mpox cases by state, with the darker shade representing states with more cases, and the lighter shades representing states with fewer cases. The hardest hit states have been California, New York, Texas, Florida, and Georgia, and Virginia ranks 13th. There have been 577 cases in Virginia. Now, in the U.S., the total number of cases has been trending downward since late August 2022, but there is variation in trends based on state or region. CDC continues to urge health departments, clinicians, and the public to remain vigilant, institute appropriate infection prevention and control measures, and notify the public health authorities of suspected cases to reduce spread. The epi curve in the top right shows all U.S. Mpox cases, and you'll see there's a distinctive peak in cases that occurred in the summer of 2022. In the center, we see all of the cases reported in 2023, which are the blue bars, and the 7-day moving average of cases is the orange line. The average number of new cases has fallen from 450 a day in August 22 to a range of 4 to 8 cases a day as of December 2023. Now, in the spring and summer 2023, there were 2 jurisdictions, Chicago and then Los Angeles, that reported an uptick of cases. And several other U.S. jurisdictions like San Francisco, San Diego, and Oregon also reported some smaller increases in Mpox cases. So these increases in cases in multiple jurisdictions, it signifies that this outbreak is not over, and we have to continue the work to prevent Mpox transmission. This figure shows U.S. cases by age and gender, and you can see the overwhelming majority of U.S. cases are in men, and they're represented in this figure in dark blue, and most cases are within the age range of 21 through 55 years old. This figure shows distribution of U.S. cases over time by race and ethnicity. Now, in the early stages of the outbreak, cases were primarily occurring in non-Hispanic white men, which are seen in the figure in dark blue. But as the outbreak progressed, we saw increasing numbers of cases in non-Hispanic Black or African American people, who are seen in the figure in orange, and Latino or Hispanic people, who are seen in purple. Disparities have been observed in this outbreak, as Mpox has disproportionately affected racial and ethnic minority groups. When we look at the overall race and ethnicity data in the U.S., we see a nearly equal distribution of cases, so that there are about 1/3 of cases who identify as Black or African American, 1/3 that identify as Hispanic or Latino, and 1/3 that identify as white. Thank you. So last May, CDC authors published a summary of the domestic Mpox response so far, and they described the epidemiology of the U.S. cases and the outbreak, as well as the public health response. Now, the authors reported the majority of cases have occurred in adult men who have sex with men and in people aged 21 to 55 years old. Similar to what was seen globally, here in the U.S., the outbreak was disproportionately affecting people with HIV, and 38% of the Mpox cases were in people with HIV. As I've mentioned, health disparities were also seen with racial and ethnic minority groups, and Black and Hispanic people were disproportionately being affected by Mpox infection. They also found the majority of deaths were in Black people, and furthermore, 94% of people who died were immunocompromised because of HIV infection that was poorly controlled. Now, these data highlight that there is overlap with Mpox and HIV infections, and both epidemics are interacting with each other. And it shows the importance of integrating Mpox into routine HIV and other STI care. And also, these data demonstrate that there has to be a focus on equity when addressing Mpox prevention, education, and access to vaccines and treatment. Let's look at some of the data here in Virginia. This figure shows Virginia's epidemic curve. You'll see the gray shading on the right of the curve, and that just means the data is incomplete for the most recent weeks. As of January 16th, there have been 577 total confirmed cases with 31 hospitalizations and 2 deaths. And based on the epidemic curve, cases peaked in Virginia also in August 2022 with an overall downward trend since then. In 2023, there were 10 sporadic Mpox cases, with the most recent case being reported in the week ending December 16th. And fortunately, in Virginia, we have not seen clusters of cases as other jurisdictions have. This figure shows Virginia cases by sex. The majority of Virginia cases have been in males. And this figure shows cases by age group. Again, cases have been seen predominantly in middle age groups, with most cases in the age range of 20 to 39 years. This shows cases by race and ethnicity. Blacks make up the majority of cases, followed by whites and then Latinos. Now, VDH has taken action to contain this outbreak as quickly as possible. This slide illustrates several of those actions. So VDH asked providers to immediately report suspected cases to the local health department, even if testing is being conducted at a commercial lab. VDH investigates all reported suspect cases and facilitates testing at the state lab, DCLS, if indicated. Close contacts are identified by the LHDs and monitored, and the LHD also provides counseling to contacts about post-exposure prophylaxis or vaccine, and the importance of quickly seeking care if they should develop symptoms. And lastly, wastewater testing for monkeypox virus has been performed in Virginia. The incubation period for Mpox ranges from 3 to 17 days, with an average of 5 to 6 days. Mpox is spread when there is close contact with lesions, body fluids, large respiratory droplets or secretions, such as during prolonged face-to-face contact, or contact with contaminated materials such as towels or bedding. And while many Mpox cases so far have been in people who identify as gay, bisexual, or other men who have sex with men, anyone can get and spread Mpox through close contact. And most of the spread in the current outbreak has been from close personal, often skin-to-skin contact, including sexual encounters with another person who has Mpox. Most of the spread has been from male-to-male sexual contact, but there's also been transmission due to contact within households, heterosexual sexual contact, and Sharp's injury from a needle or a scalpel. Now, Dr. Wheeler will be discussing the clinical presentation of Mpox, so I won't spend a lot of time on this slide. I will just highlight that the symptoms of presentation in this current outbreak have been different than what was considered classic Mpox. So the rash in this current outbreak has frequently been located on mucosal areas, so places like the genitals and in around the anus and in the mouth. And we've also seen rash lesions that are localized to one area of the body, and they're not always in the same stage of development. And I know that Dr. Wheeler will also be talking about Mpox and HIV, so I won't go through this slide too much. I will just say that remind everybody that 38% of people with Mpox have also been co-infected with HIV, and most reported cases of severe Mpox have been in people who are living with untreated HIV, so they have low CD4 counts and substantial immunosuppression. And CDC has made several recommendations to providers that are listed here, but I think in the interest of time, we'll keep moving along. So this slide highlights some of the infection prevention and control measures for patients with Mpox. For patients who are isolating at home, it's best if they isolate in a room separate or away from others if that's at all possible. They want to try and limit their exposure to pets and other people, try not to share potentially contaminated items, and avoid activities that might spread material from lesions. It's important to routinely clean and disinfect commonly touched items and surfaces. Now, in the hospital, it's best, again, if patients are isolated in a single room with a dedicated bathroom. Staff should use PPE, so that includes gowns, gloves, N95 respirator, and eye protection. It's important to limit patient movement unless it's necessary for medical care. And if a patient does need to be transported outside of their room, they should wear a mask as well as cover their lesions. And then staff should avoid activities that could spread lesion material. So they want to not do things like shaking laundry. And while gay, bisexual, and other men who have sex with men make up the majority of cases in the current outbreak, anyone regardless of sexual orientation or gender identity who has been in close personal contact with someone who has Mpox is at risk. Now, there are several prevention measures that people can take to prevent infection. Jynneos vaccine is safe and effective before exposure to Mpox or as post-exposure prophylaxis or PEP. And I know Dr. Ramayo is going to be talking about Jynneos vaccine at length, so I won't go through it too much, but just in terms of PEP, I want to highlight that it's best if given as early as possible, so ideally within 4 days after exposure. Other ways to prevent infection include avoiding skin-to-skin contact with people that have a rash that looks like the monkeypox virus rash. If you're planning to attend a gathering where you might be in close proximity with others, you want to consider the risk. Having multiple or anonymous sex partners may increase chances of getting Mpox, so temporary behavior change, such as limiting number of sex partners, may reduce exposure. And lastly, washing hands frequently or use of alcohol-based hand sanitizer is an effective way to prevent Mpox as well as all of the other infections that are circulating. Now let's summarize where we are currently with the Mpox outbreak. So case numbers have declined since peaking in August 2022, and this is likely due to a combination of things. So we know that there is some immunity, both natural and vaccine-induced, as well as there have been some behavior changes that are causing the numbers to decrease. Now, despite this decrease, public health continues to monitor Mpox trends and ensure that people have access to vaccination and treatment. Since spring 2023, there have been those 2 large clusters of Mpox in Chicago and Los Angeles, as well as some smaller increases in other jurisdictions. And again, this highlights that Mpox is not over. It is still here with us. And we have to continue our focus on vaccination of individuals who are at risk, especially in advance of events where people might be engaging in activities that put them at increased risk. And 2-dose Jynneos vaccine is our best tool for prevention. Now, I want to talk a little bit about some of the more recent developments with Mpox. So on November 23rd, WHO released a report about an ongoing Mpox outbreak in the Democratic Republic of the Congo, or DRC. And this outbreak was notable for many regions. So first, this is a really large Mpox outbreak. There are over 12,000 clinically diagnosed cases since January 1st of last year, and cases are being identified in new areas, including in some of the large urban areas. Now, second, the DRC outbreak has been caused by a different strain of the virus. It's caused by clade 1. And if you recall, there are 2 main clades of the virus, clade 1 and clade 2. The 2022 global outbreak has been caused by clade 2, specifically clade 2b, but this outbreak in DRC is actually caused by clade 1. Now, clade 1 can cause more severe Mpox, and it spreads more easily than clade 2. And third, this is the first time that clade 1 virus has been documented to spread by sexual contact, including among men who have sex with men. Now, other reasons this situation is concerning are stigma against the LGBTQ+ community in DRC, and as well as limited or no access to testing, treatment, or Jynneos vaccine. So this may make it harder to control spread in this area. Now, in terms of infection control, including specimen handling and waste management, clade 1 Mpox virus is categorized as a category A infectious agent. So it requires more stringent practices than clade 2. Now, there is some good news. We don't expect performances of testing, diagnostics, vaccine, and treatment to be any different between clade 1 and clade 2. Now, overall, the WHO assesses the risk as moderate for the general population in neighboring countries and for gay men, bisexual men, and other men who have sex with men and sex workers. So CDC is closely monitoring the situation in DRC. To date, there have been no clade 1 Mpox cases identified here in the US, and the risk is considered low at this time based on the available information. CDC published a health advisory in December to ensure clinicians are aware of the situation and the possibility of clade 1 Mpox in people who have had recent travel to DRC. So if suspected Mpox cases have traveled to DRC in the 21 days before illness onset, these are the recommendations. So for diagnostic testing, follow regulations for Category B infectious substances. It's important always to collect a detailed travel, sexual, and social health history. Contact the LHD to rapidly report the suspected case and to coordinate clade-specific testing through DCLS, our state lab. So it's important to make sure that DCLS approves the testing before specimens are shipped. And our state lab is validating a clade-specific test. It's not currently available, so until that time, specimens will be shipped to DCLS and then on to CDC for further testing. We also remind providers to please swab multiple lesions and collect 2 swabs per lesion. Now, for waste management of patients who have traveled to DRC in the 21 days before illness onset, it's important to consider the clinical picture and contact the LHD to discuss specifics of waste management. So now I want to highlight some of the ways providers can collaborate with public health during the ongoing Mpox response. So while cases and news coverage have substantially decreased, Mpox is still out there, it's still spreading, and risk remains. So we ask providers to please keep Mpox on their radar when they're seeing patients. Please continue to promote vaccination, education, and increasing awareness. There are numerous educational materials available both on the VDH and CDC websites to use as resources. And we encourage providers to integrate Mpox services into HIV and STI clinics and include Mpox on your sexual health checklist. Jynneos vaccine is safe and effective. It's the best tool that we have to protect people who are at risk, and we need to continue outreach and education to the populations most effective. Now, we know vaccine coverage varies greatly by jurisdiction. CDC put out an MMWR last year that said that really over 1 million doses of Jynneos vaccine have been given, but only 23% of the at-risk population has been fully vaccinated. And here in Virginia, 19% of those at risk have been fully vaccinated and 28% have received 1 dose. So we still have a ways to go to close that vaccination gap. So if you're a provider and you are not administering the vaccine, please consider doing so. We have instructions for enrolling as a vaccine provider on our VDH Healthcare Provider Vaccine Guidance webpage. If it's not possible for you to give vaccine in your clinic, we encourage you to refer folks to the CDC's Mpox vaccine locator. And lastly, I want to highlight that VDH actually has more than 1,000 doses of Jynneos vaccine that are set to expire at the end of this year. So now is a great time to start planning those vaccine clinics, coordinate with your community partners, conduct vaccine outreach events so that we can use this existing vaccine to protect people at risk. If you suspect Mpox, as I've mentioned, be sure to collect that detailed sexual, social, and travel history for the 21 days before symptom onset. Test for Mpox, even if the patient has a history of having Mpox in the past, or if they've been vaccinated, because there have been reports of patients getting Mpox more than once, and there have also been reports of patients getting Mpox after vaccination. Keep in mind when testing a patient for Mpox, also test sexually active adolescents and adults for HIV as well as other STIs because concurrent infections are possible. And a reminder, if a patient traveled to DRC in the 21 days before symptom onset, coordinate sending the specimens to DCLS so that they can then be forwarded to CDC for clade-specific testing. Otherwise, if a patient does not have that history of travel to DRC in the 21 days before symptom onset, it's fine to send those specimens to a commercial lab, as you have been doing for routine testing. Providers must notify the LHD of any patient with suspected Mpox. We have an LHD locator tool listed here, and this can be used to find the appropriate health department in your area. Providers, we also ask that you please encourage your patients to cooperate with the health department to facilitate follow-up, vaccination, and monitoring of close contacts. And this slide just highlights a few things that providers can do for managing patients with Mpox. It's important, if needed, to consider consultation with CDC for questions about patient management. And these are the contact information for the CDC's clinical consultation service. We also ask that you speak to your patients about the STOMP trial, and I know there'll be some discussion later this morning about that trial, but this is a trial looking at the effectiveness of TPOXX or tecovirimat in patients with Mpox. And you do not have to have severe Mpox or be at risk of severe Mpox to enroll in this trial. So we ask providers to stay connected with public health. So please sign up online for our VDH healthcare professional newsletters. You can also sign up for CDC COCA updates and CDC HAN updates. We have a lot of information on Mpox available on our VDH Mpox web pages. And we have 3 more of these Mpox training sessions coming up in different regions of Virginia. So we ask that you encourage your colleagues to attend these. This slide just lists some of the resources VDH has available. I want to highlight the last couple of bullets on this slide. So we have printed materials available, as Jenny mentioned, on the tables outside. You can also request printed materials be sent to you. There are 2 REDCap surveys. One is for local health departments. One is for folks outside of the local health department. So please feel free to take a picture, log on and fill these surveys out to get some information for you. And these are the take-home messages. So in general, the risk of Mpox infection for most people is low. The current outbreak has been declining. It's declined substantially since it peaked in August 2022, but sporadic cases and some clusters continue to occur here in the US. In the current outbreak, most people have reported close, sustained skin-to-skin contact, including sexual contact with other people. Now, the current focus is on awareness, education, and vaccination for people at risk. Keep Mpox in mind when evaluating patients, particularly if they have a diffuse or localized rash. Incorporate Mpox into routine STI and HIV care. Keep in touch with the LHD to report suspected cases, and stay up to date on the information available from VDH and CDC. I want to thank you for all of the hard work that you've put into working on this Mpox response. We appreciate all of your efforts.